Okay. Admit all. There was a very interesting surprise for us because we mentioned, we thought that Ukrainian physicians don't speak English very well. But after registration, we were very surprised that mostly more than 50% of our physicians can speak English fluently. That was very surprising information even for us. Because in our questionnaires, when we ask what is the level of your foreign language skills, mostly not very big number can say that they can speak English fluently, but maybe time is going on and skills increase extremely, because now our today's time is very important to be in touch with the whole world.
Sure.
Okay, 1 minute we will wait and start. Okay, I will start from in Ukrainian, and after that we will change our language in English. Доброго ранку, шановні колеги. 10 година ранку, і ми раді вас вітати на унікальній події, якої ще в Україні не було. І ми дуже раді, що ми маємо певне відношення, як Асоціація лікарів фізичної та реабілітаційної медицини, до можливості навчатися у найкращих експертів, які є практиками, науковцями, а також прекрасними спікерами, і можуть доносити інформацію в найкращий спосіб для того, щоб поширювати найкращі доказові знання з певних галузей знань з реабілітаційної медицини. Сьогодні нашим з вами гостем буде професор Стефано Негріні з Італії, з Мілану, який є одним з найкращих в світі експертів з лікування та реабілітації сколіозів. Сьогодні у нас буде з вами просто неймовірна можливість почути інформацію, то, що називається з перших вуст. Саме тому ми взяли на себе відповідальність не перекладати лекцію для того, щоб не витрачати час. Сьогоднішня лекція буде тривати близько 3 годин, з перекладом це було біля 5 годин. Тому я думаю, що більшість із вас англійською володіє, і якщо буде така потреба, ми потім з дозволу професора будемо мати можливість поділитися цією інформацією з тими, хто був присутній сьогодні. Тому дуже дякую вам за реєстрацію, не будемо витрачати часу. Я зараз передаю слово нашому шановному професору, і ми починаємо нашу роботу. Good morning, dear colleagues. Let me introduce to you one of the best experts in the area of physical rehabilitation medicine, especially in rehabilitation and treatment of idiopathic scoliosis, Professor Stefano Negrini. He is one of the best experts not in Europe but in the world, and today he will share with us scientific evidence information how to treat and rehabilitate this very commonly spread disorder. Good morning, dear Professor Stefano Negrini. We are extremely glad to invite you, and we are very grateful to you that you agreed to share with us and to be present today. Thank you very much.
Thank you for inviting. Yeah, you asked me to present a little bit myself. I am a full professor at the University of Milan, and I am since almost 18 years, 17 years, I'm chief editor of the European Journal of Physical and Rehabilitation Medicine, and I work very well with the Ukrainian colleagues in the PRM bodies community, so in the UEMS PRM section and board. I am also director of Cochrane Rehabilitation, while scoliosis is my field of interest clinically. Nowadays, I practice only with idiopathic scoliosis during growth. This is all my clinical practice that takes me almost 40%, 50% of my time, and for the rest is teaching and research on scoliosis and on evidence-based medicine application in physical rehabilitation medicine. Today I will give you a lecture on scoliosis and on at the same time a view of an approach that can be evidence-based to physical rehabilitation medicine. This is done in the field of scoliosis in this case, but is applicable in all other fields of physical rehabilitation medicine. So if it is okay with you, I will start sharing my screen.
Yes, please.
Can you see it?
Perfectly, thank you.
Okay. So we will have 4 different moments, and each one will be followed by a question and answer, so that we can interact a little bit. The first one will be about AIS and what is relevant of the current knowledge about idiopathic scoliosis for a good PRM approach. Then we will speak about bracing. I will give you some information about how we approach bracing. And then we will speak about physiotherapeutic scoliosis specific exercises and the tools we apply for this. So let me start with a little historical view can you see the entire screen, or there is a black part where you are there are your faces? No, you see everything?
Yes.
Okay.
Everything
okay.
is
okay. So as you can see here, for a long time we had a gradual decrease of the research on the tools of physical rehabilitation medicine to treat idiopathic scoliosis. You see on the, you also see my mouse, correct?
Yes, we can see it.
Okay, so while the research on surgery continued to grow, the research on bracing and exercises was slowly constantly going down since the 70s up to 2000. And that was somehow related to the idea that we were almost everything was already known, and also because of the shift of the specialty that was mostly dealing with scoliosis, that used to be orthopedic surgeons, to become only surgeons and not anymore being engaged in the so-called conservative treatment. Nowadays, I prefer to call it a rehabilitation approach to idiopathic scoliosis. And surgeons were interested in surgery and continue to do research on surgery. And that is why down in 2004, with a group of colleagues around Europe, we started a new society. And those of you who are interested in idiopathic scoliosis should join this International Society on Scoliosis, Orthopedic and Rehabilitation Treatment that deals only with the conservative treatment and the rehabilitation treatment of scoliosis. And due to the push of this society, the world really changed, and research started again, and quite recently also the worst enemies of the approach, the conservative approach to idiopathic scoliosis, that were in Northern Europe and mostly of the US, where it was thought that there was no evidence in favor of bracing, so braces were not proposed anymore, and even worse for exercises. In the Eastern Europe is a little bit different. Like in Southern Europe, these approaches continue to be practiced, but the English-speaking country were really going in another direction. And thanks to the research we have done in these years, the thing has changed, and nowadays there is a growing interest worldwide on bracing and exercises. One of products that came after a few years of existence of SOSORT were the SOSORT guidelines. Here you see the first edition, And these SORT guidelines were based on two main concepts, and we will discuss this. These are at the base of all what I will present to you today. One is an evidence-based clinical practice approach. So the understanding that when we approach a patient, we have to consider three different elements. One is the current best research evidence. That per se is not enough anyway to approach the patient. Then you have to combine with your own clinical expertise, and you have to combine with the patient's values. I used to give an example here. Just imagine a patient with a 60-degree scoliosis. That means a patient with a scoliosis that is for sure surgical. We will speak about the threshold of scoliosis in a few minutes. And the patient and the family had already another case of scoliosis, and this relative died because of the surgery. And these patients don't want at all to be operated on. So the patient values are fully against surgery. What can you do? Then you have to move to the most close good approach for him, and that could be bracing. The other way around, you can have a patient 30-degree scoliosis, so in the area of bracing, and this patient really don't want braces at all. Because of many different reasons, or he can't wear, or he has psychological disturbances that don't allow him to wear the brace. Then you have to move again to the next thing you can practice, that will be exercises if possible, or just wait and see and hope that you will not reach the level of receiving surgery. So patient values are highly important. And the other highly important thing is clinical expertise. Each of us need to grow its own understanding and its own capacity in doing what is needed by his patients. Obviously, if you come to me with a scoliosis of 70 degrees and there is the need of surgery, I am not able to practice surgery, so I will drive the patient to another colleague. So this is the triad of evidence-based medicine and evidence-based clinical practice, and was at the basis of our guidelines. And the other thing that was introduced in the guidelines and is still valid is the concept that was developed many years ago by one Italian colleague that was one of the master in years ago about scoliosis. And he used to say that treatment of scoliosis is a step-by-step, where the lowest step is the less invasive, but is also the less effective. So the more you go up on the steps of treatment, the more you require to the patients, but also the more effective is the treatment. So at that time, it used to be observation, exercises, plastic braces, casting, and surgery. And the real point with each single patient is not to undertreat or not to overtreat. Because if you undertreat, you give more freedom to the patient, is less invasive, but then scoliosis progresses. If you overtreat, you achieve incredibly good results, even too much, but the patient has much more discomfort and much more impact on its quality of life. So it's really a question of getting expert and being able to choose the right step for the right patient. In 2016, we had the second edition, and it's almost time to arrive to the third edition of these guidelines, because 5 years changes a lot. And this is the last document that you should look at to have all the information that are relevant. This is open access. You can find it very easily searching on the web. And I suggest you, if you want to work in this field, to read carefully and to learn from all the recommendations reported in these guidelines. It's a document of almost 40-45 pages. It's a little book, in fact. Thanks to this, the situation has really changed. And as you can see, gradually research on bracing and exercises started growing again after 2004, after the foundation of SOSORT. So let's dive now into the main presentation. What is scoliosis? Scoliosis is not an attitude, is not a posture. Scoliosis is a bone deformity. The bone is deformed by the pathology, and this deformity reflects on the trunk, and also the trunk is consequently deformed. The deformity is in all the three planes. We used to think of scoliosis as a frontal plane disease, because this is what we see in the radiographs. And we see very well on the radiograph the lateral curve and the rotation. And what we usually takes less care of is the distortion, the distortion of the sagittal curves. But this is probably one of the most important planes, in fact, much more for sure than rotation, because in the adulthood, the problem that comes from scoliosis are always on the sagittal plane. Patients with scoliosis tend gradually, with aging, to fall frontally, to fall back, and all scoliosis become at one point kyphoscoliosis. So, but that comes as a distortion, a biomechanical distortion, consequent to what is happening during growth, that is a reduction. So it's not a bending forward, but is a reduction of the curves with the tendency of the kyphosis to go toward lordosis, and the tendency of lordosis to go toward kyphosis. And when you have a flat back, then you have also the worst prognosis. So with the same lateral curve, but a flatter back, you will have a prognosis that is much worse. So nowadays, all the experts on scoliosis are taking a lot care of the sagittal plane while treating the frontal and the horizontal plane, because that is where scoliosis creates the maximum problem. And we will come back to this quite a lot. So I stress the point because really we are too much concentrated on the frontal plane, but the distortion on the sagittal plane is really highly important. Why we treat scoliosis? This is a question that each one of us should always ask himself or herself. Why we treat any kind of pathology? Do we treat scoliosis because we want a straight back? We want a perfect anatomy? No, not for sure. This is not what we are thinking about. In fact, we treat scoliosis to have a functional spine. And we know very well that spine can function well enough even with a scoliosis when the scoliosis is not too important. So years ago at the start of SOSORT, we tried to define the reasons why we treat scoliosis, and one main reason is aesthetics. Scoliosis is a deformity of the spine and the trunk, a fixed deformity, and hit mostly girls. Almost 70% of idiopathic scoliosis are in girls, and this aesthetics can be impaired quite a lot, and this is one of the reasons to treat scoliosis. Then we treat scoliosis because of pain in adulthood, and I will show you the data about how frequent when pain becomes important in the field of scoliosis. And then, as I told you, to avoid posture inflections in old age, and that is something that we can preventing progression and achieving the best and most balanced spine at the end of growth. About breathing and heart difficulties, this used to be the reason, but then since almost 15 years, 20 years, we know that is not so important, the impact on the lungs that exists. There is a reduction of the vital capacity, but people are not so greatly impaired as we used to think. And this impact, in fact, is mostly on the secondary scoliosis, is mostly on the infantile scoliosis that appear in the first 2 years of life, because those impact on the development of the lungs. But when the lungs are already developed, we don't have really that much breathing and heart difficulties. So the first three are the real reason for treating idiopathic scoliosis. During these years, some thresholds have been identified. These thresholds are reported here in terms of Cobb degrees, that are the measurement system. I don't go in detail on how you measure the Cobb degrees, obviously, because I expect all of you to know about it. And the Cobb degrees are a little bit the gold standard of measurement of scoliosis. And we always refer to Cobb degrees, but I just want to stress here that Cobb degrees are just a reference. And with the same Cobb degrees, you can have a curve that is decompensated, as a flat back, is highly rotated. So there are negative prognostic factors and there are positive prognostic factors that change a little bit these thresholds. But anyway, is easy to remember using this threshold. And the first threshold is for diagnosis. Below 11 Cobb degrees, you don't make diagnosis of scoliosis. Even if so stressed that if you have a curve even of 3 degrees, 4 degrees, with a prominence, that means the difference when you bend forward between one side and the other side of the trunk, a real prominence due to the little scoliosis that you have seen, you still have to follow up this patient in time, because that is a risk situation. But anyway, by worldwide agreement, the diagnosis is from 10 Cobb degrees. Then we have the highest threshold, that is 50 Cobb degrees, 45, 50 Cobb degrees. That is the threshold for surgery. And then we have an intermediate threshold. This intermediate threshold has been defined quite well by research, and is the threshold of problems in adulthood. We know that below 30 Cobb degrees, the risk of progression in adulthood, by the way, when I was young, we used to think that scoliosis didn't progress in adulthood. Now we know very well that is not true. And research has produced this threshold. If you end your growth below 30 Cobb degrees, the probability of progression is very, very low. From 30 Cobb degrees on, this probability tends to gradually increase. And the other threshold has been defined at 50 Cobb degrees, where the probability is almost certainty of progressive progression in adulthood. And 30 Cobb degrees is also significant for back pain. Research has shown that below 30 Cobb degrees, the probability of having back pain and chronic back pain is the same as in all the population, while above 30 Cobb degrees, this probability increases. And that makes, in a way, a highly significant threshold for all of us, because it means that if you end growth with a curve around 20-25 Cobb degrees, you are not very much concerned for the future of your patient. While if you end growth with a curve above that level, concerns gradually raise. And that is a target for us. That means that, and I will show you in this explanatory graph, As you can see here, as we said, up to 30 degrees, the risk of a health problem increases, obviously, but this increase is negligible. And you really, okay, don't take as this 5% risk at 30 degrees is just a statistical thing, because the probability of having problems is very, very low, but we don't know exactly what this number is. But anyway, for sure, it grows gradually, and then suddenly grows a lot. And in 20 degrees, from 30 to 50 degrees, you reach the almost certainty of problems in adulthood. That means that when you are here, it doesn't count too much. If you have 5, 10, 15, 20, even 25 degrees, your risks are very, very low. If you are here and it doesn't change that much. If you have 60, 70, or 80 degrees, you are really, okay, it changes because the impact of the surgery you will have to be submitted will be much worse. But in terms of risks of having problem in adulthood, you will have risks. So just imagine that you are a very good conservative physician and you find a patient with 70-degree curve, and you are incredibly good, and you are able to take him back 15, 20 degrees, but you move him to 50 degrees. What does it change for his future? Almost nothing, almost nothing. And if you have a curve of 20, 25 degrees and you take it down to 5, 10 degrees, you are renormalizing anatomy, but you are not renormalizing function, because functionally for him or for her to have 25 degrees or having 10 degrees really almost doesn't change anything. While if you have a curve of 45 degrees and you are able to go down to 30, you really change the life of the patient and his, her future. So this graph should be kept in mind just to understand what we do and why, and what we should aim at during conservative treatment. The other graph that is highly relevant is the graph of growth. This graph represents the speed of growth during growth of the human being, and the highest speed is in the first year of age, when we grow 25 centimeters. Then it gradually slows down up to age 4. And from there, we have a growth that is quite regular with some peaks. It has been described one around 7, 8 years of age, until we reach the first signs of puberty. At the first signs of puberty, the growth suddenly increases, can increase quite a lot. And then considering the sign that we mostly used about bone maturation in the field of scoliosis, that is the ossification of the iliac crest evaluated through the Risser score. When you reach Risser 1, this growth start to decrease and becomes almost zero from Risser 3, 4 on. And we know that scoliosis progresses with growth, and the more rapid is growth, the more rapid is the progression of scoliosis. And in fact, the worst period for progression of scoliosis that we always have to remember is between the first signs of puberty up to Risser 1. And from Risser 1 to Risser 3, the progression can still be quite important. And then from Risser 3 afterwards reduces gradually until reaching the perspective of adulthood when bone formation is concluded. But this graph also tells us that the worst progression of all happens, in fact, in the first years of age. And this is why infantile scoliosis that appears before age 4, so up to age 3, are the worst scoliosis, because they have this rapid period of growth that is very dangerous for the spine. And this reflects on what we what is the natural history of scoliosis. And I told you before that when you have to treat one pathology, you have to know, first of all, to understand why you are treating the pathology. And second, you have to know the natural history of this pathology, so to be able to face appropriately the pathology itself. For example, in low back pain, acute low back pain, we know very well that it's self-resolving. So you don't need to do very big things with acute low back pain. While when it becomes subacute, the risk of becoming chronic is incredibly high, and that is the moment in which you have to apply all the tools to try to avoid chronicity. So natural history tells us a lot about what we are doing and why. For infantile scoliosis, we used to have a progression throughout all the growth period up to puberty. When you reach puberty, you face the sudden progression, and this sudden progression obviously is more important. The worst is the curve, and then this progression slow down gradually. So imagine the same 25-degree curve in an infant, in a 6 years old juvenile case, or in a 10 years old adolescent case. And as you can see, the natural history is totally different. And for what we know, infantile scoliosis, excluding the very few self-resolving scoliosis that in fact are only scoliosis in the first year of age. After age 1, you don't see any more self-resolving scoliosis. Those are almost 100% surgical if not treated. While the juvenile scoliosis, they are surgical in 9 cases out of 10. And the adolescent scoliosis, at the start of scoliosis, we have now data that shows us that becomes surgical. So overcome the threshold of 50 degrees in almost 1 case out of 2. So the natural history of scoliosis is really quite bad, and we have to face it. And what we try to do, we try to improve as much as possible and stabilize the curve as much as possible. This is what we aim with our treatment. I was telling you about the natural history, and is not so well known. In fact, we made a meta-analysis a few years ago, and we discovered that most of the existing papers are really mixed, including patients not treated with patients treated. Is really quite a mess. And for this reason, we received a grant from the Scoliosis Research Societies a few years ago, and probably before the end of the year, we will be able to present our data. And we are developing, this is an example of 120 patients, natural history of 120 patients. And as you can see, there is a general trend toward progression that in some cases is very, very rapid. In some other cases is very, very mild. And even you have a few cases in which there is an apparent decrease of a few degrees without any kind of treatment, but that can have an explanation that will come later when we will speak about the exercises, and I will discuss with you about what is the structural component of scoliosis and what is the postural component of scoliosis. And when we make an X-ray, there is always also the postural element. So these are the current provisional model that we produced. This is the tendency to evolution of a 15-degree curve in a 6 years old patient. This is the tendency of a 25-degree in a 12-year-old patient, and this is a tendency in a 25-degree scoliosis in a 14-year-old patient, and you can see that there is still a slow tendency of progression. And if you combine these 3 these three curves, imagining to catch a curve at 5 years of age and 15-degree curve. This is the average expected progression. But as you can see from this graph, the average is in the middle, and then you have the extremes that can be much worse or much better. So there is quite a huge variability, but this is the current model, not yet completely refined. So you have to wait 1 year more probably to see it published in a journal with a stronger data. So as I told you, whenever we catch scoliosis, what we try to do is to improve with bracing or exercises, stabilize. And if we catch scoliosis before puberty, we also know that in many cases, very frequently, we have a progression at the time of sudden growth. And I repeat, this time is not at RESER 1. RESER score does not really allow us to catch the moment of progression. The moment of progression are after the first sign of puberty. You see the nipple that start to become a little bit more mature. That is the very first sign in girls. You see some hairs on the pubis, on the legs, and the patient changes his body shape and changes. And these are the very first signs of puberty, and those are the one you have to take care of, because then the progression will be between that moment and RESER 1. And then you know that you are in the worst period. That is red alarm zone. I used to say to my patients that treating scoliosis is like driving in the fog. When you drive in the fog, you don't see very well. You don't see exactly where you are. You know the road, you have indications, you have, so overall, you know where you are, but you are still driving in the fog because you don't know exactly with that scoliosis, that individual patient, what will do, that scoliosis, what will do to that individual patient in that specific moment. So when you see the first signs of puberty, you are at highest top alert. That means you shorten the time between control, you don't reduce the intensity of treatment, you are very ready to increase the intensity of treatment if the patient show progression. So, but still, that patient could not progress. So you are not authorized just because you are at the first signs of puberty to increase the intensity of treatment, to create more quality of life problems to him or to her, to reduce the risks of progression. So you observe, but you are very, very careful, like driving in the fog. That graph I've shown you about the growth, this is what you have to keep in mind, because that tells you where you are. That is your indication. And then you have to be much more careful when you are in the moment of maximum alert. Idiopathic scoliosis is called idiopathic because we don't know anything really about what causes scoliosis. We know that it is a family disease. We know that runs into the families, but there is not a straightforward genetic progression. So the expression of these genes, the epigenetics, as it is called, is really very different in different patients. But what we know very well is the pathogenesis, and this is what, in fact, we look at when we are treating scoliosis. The pathogenesis tells us, and that has been studied very well by biomechanicians, Ian Stokes, that performed 20 years of research and finally arrived to develop this vicious cycle in which each one of these elements has been proven by specific research. So whatever is the reason that causes the appearance of a spinal curve, that spinal curve leads to an asymmetrical loading of the vertebrae. So this leads to a chronic compression of some areas of the bones and a chronic decompression of other areas. And this leads in turn to an asymmetrical growth in which the chronic decompressed areas tend to grow more and the chronically compressed tend to grow less. And that causes a progressive wedging of vertebrae and also of discs, has been shown quite recently, leading to an increase of the spinal curve. And that creates a vicious cycle because the greater the curve, the greater the asymmetrical loading and asymmetrical growth. And this is what we try to revert with what has been called the virtuous cycles. My friend and colleague Manuel Rigo from Barcelona, Spain, developed the first one you see in red externally. That is the virtuous cycle of bracing, and I modified it thinking of exercises. Because in exercises we have to add something that is not only correcting the deformity, but is also changing the movement strategies. This is a key element, not studied yet well enough. But okay, let's look at one by one. When you put a patient in a brace, you aim at correcting the deformity as much as possible, but that correction should be kept long enough to cause a reversal of the asymmetrical loading, so compressing chronically the chronically uncompressed area, and vice versa, decompressing chronically the areas that would be chronically compressed by the scoliosis, the pathology. That will reverse the asymmetrical growth and potentially decrease the vertebral wedging. There are proofs that this can happen during the infanthood and in the very early juvenile scoliosis. We have seen decrease of wedging. We have seen it also in the Sherman disease pathology with vertebrae that were really able to reconstruct. And I also published a paper on a vertebra that was totally reconstructed during growth after a tumor that was taken out, but the vertebra was still there. It was totally flattened, and then it regrew to a normal vertebra. So a regrowth is possible, but it's possible only in the very early years of age. We don't have proof about adolescent curves, where probably the growth remaining is not long enough to really allow a reconstruction. While for exercises, as I told you, with exercises, we aim to improve posture, again, reducing the asymmetrical load, but also to improve movement strategies so that the patient rely less on its scoliosis while moving. And this can, in turn, reduce asymmetrical growth and, in the end, reduce the problem. The treatments that we have include control over time, and we have always to remember that scoliosis, apart the infantile cases, never goes back, never disappears spontaneously. So when you catch scoliosis, keep it in follow-up until the end of growth. Is 10 degrees, is 12 degrees, is almost nothing, you don't have to do any treatment. The treatment of that scoliosis is observation. So to be sure that in the red alarm zone, at the first signs of puberty, it will not progress and it will not cause problems to the patient. So observation is a treatment. That means you have to motivate the patient. And we have seen, I have seen in my life quite too many patients that you see one time, 5 years of age, scoliosis, no problems. Okay, you see at 5 years and a half, scoliosis, no problem, nothing to do. 6 years, 6 years and a half, 7 years, 7 years and a half, 8 years, and then the patient disappear because the parents think, okay, the scoliosis is not progressing, is not causing any problem. Why am I spending time? Why am I spending money to go and have this regular observation? And then the patient comes back at 15 years of age, and that curve that was 15 degrees now is 60 degrees, and you can't do anything anymore, just you can send it to the surgeon. And that is not the fault of the parents, it is our fault, because the motivation to the treatment is part of our job. And if the treatment is observation, you have to also to motivate to be observed and to keep the tension, not to create problems, because sometimes you keep the tension just to create problems. No, we don't want to create problems. You have nothing for the moment, but this could become something in the future, so we have to control regularly. Then we have scoliosis specific physiotherapeutic exercises, and we will speak of those and bracing as well. And we will not face directly the problem of surgery. I'm not a surgeon, but perhaps if you want, if you raise any question, we can discuss a little bit about the choices around surgery. And again, I told you is a step-by-step treatment. Just remember that constantly. The more you require, the more you are invasive. So it's more effective, but it's more invasive. So be careful not to over-treat, but also be careful not to under-treat, because if you under-treat, scoliosis will progress. This is the current step-by-step approach that we apply in EasyCo in my institute, that we superposed to the curve of progression that you have seen before, of risks of problems in adulthood. So as you can see, these steps follow one after the other. But you can also see that the steps are quite wide and are quite overlapping. Why this happens? This happens because with the same curve, there are two factors that plays a role. First, prognosis. With the same curve, you can have a bad prognosis because you have all the bad prognostic signs, so you can require a more invasive treatment. And the second element is shared decision making. Shared decision making is a key word of modern medical approach to any disease. And we submitted a paper, not yet published, you will see some results afterwards, about the importance of shared decision making in treating adolescents with idiopathic scoliosis. Adolescents are much better than adults. They can really jump in the fire if you ask them to do it and you explain well to them why they should jump into the fire. Why an adult, you can even explain well, it will not jump into the fire because it decides that is damaging. So if you explain well to a patient why, an adolescent, why he or she should wear the brace full time, 23 hours a day, for months, perhaps for years, because it has she has an important scoliosis, the adolescent is ready to do it, but it must be a shared decision making, explaining well, discussing well, solving the problems, finding the solutions to allow the patient to do the treatment. I can tell you that when I have to put braces on adults with vertebral fractures, they are not as compliant as the adolescents. Even if you explain very well, they just do what they want. So it's not a problem achieving compliance if you work well, if you discuss, if you speak, if you explain, if you take time, and if you confront the patient, if you try to find a solution together. And this sometimes also, for example, you have a patient that for you has bad prognostic factor, and she would require a plastic brace, but you understand that she's not ready. There are too many problems, etc., etc. You can still go down to exercises, but you will keep control much closer. And when you will have shown to the patient that with exercises the curve is progressing, then at that point, the patient will be much more ready to accept to wear the brace, and not only your word, just the proof. And that is also a thing that we have to do in the field of scoliosis, to share, to adapt our treatment also to the not only patient values, but also patient understanding of the problem and readiness of the patient to face the problem. So this is why the steps are wide, and compared to the previous step-by-step treatment, as you can see, there are more steps. Nowadays, we have observation, we have exercises, we have different type of braces. So elastic brace, the spinal cord brace, plastic brace, the classical polyethylene braces, and then we have the very rigid braces. These are the last creature developed in the last century, in the 21st century, that allowed us to avoid casting. The most prepared conservative physicians around the world are not proposing casting anymore, because we have now these very rigid plastic braces to be worn full time in these very important cases. And the highest threshold, we published a few years ago a paper that has shown that in curves between 45 and 60 degrees during growth, you can still avoid surgery and take the patients out of the surgical area in 50% of cases. And if the patients want to try to avoid surgery, you can still go up to 60 degrees, no more than that, because above really results are miracles if you think you could end below 45 degrees. This is the real thing, the real step-by-step. This is what we have found looking at almost 2,000 patients in our everyday practice. And as you can see, is exactly comparable to this curve. And you see the COP degrees, the average treatment proposed with its variation in patients with curve up to 45 degrees. So this is the distribution and the different treatment. Observation, exercises, elastic brace, rigid brace, 18 to 21 years per hour per day, very rigid brace, 18 to 21 hours per day, rigid brace 22 to 24, and very rigid brace 22 to 24. You have quite an overlap only here, because the difference between the rigid brace and the very rigid brace is you can have a comparable treatment using very rigid brace with fewer hours than using a rigid brace. And this is why you see this overlap with these two steps. And while the overlap here comes from the fact that historically we didn't have the spinal cord brace, so it's only in the last 10 years. These 2,000 patients are all patients research 0 to 2 and curves below 45 degrees. And it took us almost 15 years to collect all these patients, while the elastic brace had been used only the last 10 years before we were using the rigid brace. So now we can stop 1 second and I'm ready for some questions.
Thank you, Professor, for very interesting and very recent information. Maybe maybe our colleagues have some questions. So you have an opportunity to unmute yourself after raising your hand, or maybe you will write down or type down your question into the chat. Or you may say something about your insights if you don't have questions and everything was clear. Dear Professor, do you perform operations in your medical clinic, or you refer your patients for operation to another hospitals?
We refer to other hospitals, but we have strict collaboration with some colleagues for surgical patients.
Mm-hmm. Thank you. And after operation, do these patients continue exercise and post-operative rehabilitation program? And how long period of time, if you do this, how long period of time can it continue?
I don't have personal experience on this phase of treatment, because usually the hospital that receive the patient for surgery also has connections or directly into the hospital. They perform the rehabilitation. Usually with the current techniques, the patient can stand up and walk already after a couple of days. So is very, very rapid, the recovery of the everyday function, but they don't need casting, they don't need bracing afterwards, but they grow up 5, 6, 7 centimeters because of the lengthening of the spine. So all the body changes its shape, and they have really to relearn to do plenty of things. So the rehabilitation process is mostly related to make them relearn to move properly. So this is what is usually done. It takes, in fact, usually takes a few months before they can do almost everything as before. Also because at the beginning you don't have to stress too much the fusion.
Thank you. And Professor, we usually have low compliance of exercise performing at home, as usually until a patient can see fast progression of scoliosis. Do you have some maybe know how to tell, how to explain patients' parents how to be more compliant to perform a rehabilitation program?
The best way to keep compliance is follow-up. In our experience, we ask patients to be seen by the physiotherapist from once per month to once every 3 months. So that depends on the distance, depends on the possibility to reach the hospital, the institute, etc. But the more they are seen by the physiotherapist, the more compliant they are. And the physiotherapist has 2 things to do. One is change, even not that much, but change the exercises, because boredness is a real enemy. So if you do the same exercises all your life, you just get bored and you stop. So changing the exercises, and second, motivate the patient constantly. Motivate, and motivation is the real changing thing. And I usually see that parents that are not compliant, so they don't come frequently enough to the physiotherapist, make the kid not compliant, because it just lose motivation. So keeping high motivations depend on the contact with the physiotherapist, but the physiotherapist must work on that. So usually in our institute, the medical consultations is every 6 months, unless you are in the red alert zone, while the physiotherapy consultation is from a minimum of every month to a maximum of every 3 months, but no more than that. Otherwise, for 2 reasons, in fact, when you don't change exercises, you are not improving anymore. So if you do the same exercise more than 3 months, then those exercises are finished. Probably even less, probably a couple of months is more than enough doing the same thing constantly. And the second reason is motivation.
To motivate patients, do you advise psychologist consultations in cases when you have an opportunity to motivate patient more, or you use only physical therapist?
We have a
in this?
psychologist in our team. The psychologist mostly trained the physiotherapist and the usually a few patients accept to go to the psychologist, but mostly not for the exercises, for the bracing. So there are a few patients who really need the psychologist, while all the others need a psychological approach from the physiotherapist and the physician and the orthotist. So the whole team must have a good psychological approach with the help of psychologists when you are in doubt, etc. And in very few cases, a real psychologist. But it's good to have a psychologist on board.
And one more question: how many times per day should you to advise to patient to perform their home exercise program to achieve more effectiveness? In
our experience, we moved from 2-3 times a week for 45 minutes, and nowadays we do 15 minutes per day, much easier to do, and that also increases compliance, and is probably the best solution. Also because nowadays we don't think anymore of the exercises. I will. You can ask me after we discuss the exercises at the end of this session. So okay. I will come back to this.
Okay. Thank you. We have 2 questions from our physicians. The first question is from Ivan Kazayev. What is your opinion about effectiveness, compliance of elastic braces?
As you have seen in my graph, elastic brace is something more than exercises, something less than plastic braces. We use them only in curves between 20 and 30 degrees, no more than 30 degrees. If we want to improve, we don't rely on the elastic brace, we use the plastic brace. And as I shown you in that curve, when you overcome 30 degrees, we want to improve. It's not enough just to stabilize. So we think of elastic brace as a stabilizing instrument. And we have avoided plastic braces to quite a lot of patients through elastic braces. So they are effective, but they are effective in a specific area. In terms of compliance, at the start is better because patients prefer mentally the elastic brace. Then when you have a patient who has worn the elastic brace and the plastic brace, 50% say it's better plastic, 50% says it's better elastic because they have totally different problems. The problem with the elastic brace is that it constantly moves, so you constantly feel it on yourself, is creating some skin problems. The plastic brace is problematic in the summer. It's terribly hot, while when it is worn well, you don't see it on yourself. So it's much more stable and patient just forget it, while with spinal cord, you cannot forget it. So the comfort, but as is also been shown by a study a few years ago, the comfort is 50% each preference. And the compliance in the long term is better with the plastic braces because in our approach, we gradually reduce the number of hours. While with the spinal cord, you have to keep 20 hours per day constantly, and not in reducing the hour can increase a little bit the problem of compliance. It is also true that the patient with the spinal cord on is highly motivated to avoid the plastic brace, so that also allow to keep the balance. So you have always to work a lot on compliance, a lot of speaking, a lot of talks, and that helps.
So it is entire team member teamwork.
Exactly, absolutely.
And the last question for this session, I think, Professor, tell please, do you use screening programs in Italy for early diagnostics of scoliosis? And if yes, who provide this early screening, and how, what is the way of the screening?
Is a huge problem. Screening is a huge problem. While on one side, screening has shown to be really important, on the other side, it also creates a huge number of patients treated that don't need really treatment. So screening is useful, but you have to do it properly. You have to remember that scoliosis is 5% of the population. And if you perform a screening and you ask for treatment, or you can ask for radiographs up to 7-8% of the population, and then you should go to treatment no more than 3 to 5% of the population. If you are doing more than that, your screening is really over-treating, overwhelming the population of problems that are not really real problems. And this is what we have seen too frequently. And this is what has also driven many health nation systems to stop screening programs. And that happens also in Italy. As far as I know, there is only one region in Italy, that is Sicily, but is still continuing to do screening. And this has happened all over the world. So the problem is not screening, is the way you do the screening. So you should be highly selective and people very well prepared. Usually screening require a first step by trained, could be nurses, could be physiotherapists, could be even teachers. If you teach them well how to identify a prominence, then you need the second level that is done by the expert and the coordinator. And then you have a third level that is the radiograph. So at the first level, you should not select more than 10%. At the second level, you should not select more than 6-7%. And the third level with the radiograph, you should reach the 3% that should be the probability of treatment need. So you should have this target in your mind. We are not the only one. We have developed during the lockdown period a screening tool, an online screening tool for parents, so that parents themselves can identify some signs and eventually require the consultation of physician. But that has not been studied. So it's just a tool, an experience-based tool that we have provided. And I know that there are other people around the world that are working on something like that to allow parents to self-screen, so to reduce the cost, because that is the other very highly relevant problem.
Maybe this tool will require multi-center or multi-state studying, and we are ready to participate in this scientific researches if you will let us to participate.
Just write to me and we can find an agreement by email. If you collect if you have a screening process going on somewhere in the country, we could compare the screening process with the self-screening. That could be quite interesting study, in fact.
Very good. Thank you. Thank you for your answers, dear professor. Do we need a small break, or
we could do
continue?
A 2 minutes break, no more than that.
Okay. Thank you. Colleagues, we have 2-minute breaks, and after that we will continue. The first hour was quite intensive, so after 2 minutes we will start again. Okay, thank you.
Thank you.
Шановні колеги, не від'єднуйтесь, 2 хвилини перерви і ми будемо продовжувати. Якщо є якісь побажання, можете особисті повідомлення писати в чаті, або якщо є якісь запитання, паралельно в чаті ви можете їх задавати, і, звичайно, ми їх озвучимо, як тільки у професора буде можливість відповідати на запитання. Дуже дякую вам за активну участь у сьогоднішній роботі. Щодо сьогоднішньої лекції, професор дозволив поділитися інформацією, яку він сьогодні нам дає. Звичайно, це не для поширення, а лише для особистого використання. І коли він нам надішле ту частину лекції, яку можна буде поширювати, за тими ж самими електронними адресами, за якими ви зареєструвалися, наш оргкомітет залюбки поділиться з вами інформацією. І щоб ви могли потім передивитися щось, можливо, якісь питання виникнуть, і ми таким чином будемо мати максимум користі від сьогоднішнього нашого навчання. Ще хвилинка на перерву і далі будемо продовжувати. Так що можна приготувати собі смачної кави, зробити санітарну паузу і будемо продовжувати. Welcome back. Let's continue, Professor.
Perfect.
I asked to our participants, to our colleagues, to ask questions, but for these sessions, the first session, we have no written questions, and for the next part, they will prepare their questions, and we will have no any delay in our studying process. Welcome, okay. Professor. Please continue. Thank you.
Okay, let's move to bracing. As I was telling you, there was a long period of time in which bracing was considered without evidence. But this study that was published in the New England Journal of Medicine, financed by the National Institute of Health in the US with $5 million, was a randomized controlled trial, and that was stopped by the ethical committee because of the great efficacy shown by braces, and that was the surprise of the main researcher, that was Stuart Weinstein. Stuart Weinstein is a surgeon, is a very good researcher, but he used to be the person who was against bracing, and he used to say, bracing, there is no evidence, should not be applied. And as a conservative community, we were very, very much afraid of the results of these randomized controlled trials, because our colleagues, orthotists that were working with the research team were telling us that results of those braces were awful. In-brace correction of those braces was really bad. And when they asked the researchers, and they told the researchers that the correction was not good enough, the researchers answered, this is a real life study. We want to see if the real everyday application of braces function. And at that time, the US was the place, and still is, in fact, the place where there are more difficulties in having good braces and good bracing. But nevertheless, the result was much, much better than the natural history. And the aim of the study in curves of patients between 20 and 40 degrees Cobb, research 0 to 2, was to avoid 50-degree curve. And what surprised the researchers was the natural history, in fact. In fact, 1 out of 2 patients only observed and identified with this kind of scoliosis progresses above 50 degrees, while this becomes 1 out of 4 using braces. So bracing was so effective that instead of recruiting almost 250 patients as it was expected, they stopped recruiting at 116 patients randomized. Then there were also 126 patients observed, and the results were not different between the observed and the randomized patients. Also what was found, it was a positive association between the hours of brace wear and the rate of success. So the more you wear the brace, the better are the results. This is quite okay. It's just something that we all know, but was not proven until that time. And after that, we had a Cochrane reviews published on braces for idiopathic scoliosis. And there we identified 7 studies that were introduced. And the results were that the braces reduces progression, and they can work on high degree curves above 45 degrees. And in low degree curves, elastic bracing is still effective, but less effective than rigid bracing. And that is the orientation you have seen in our EasyGo step-by-step approach. So we still use elastic braces because they are effective in curves between 15 and 30 degrees, but we know they are less effective than rigid bracing in the same kind of curves. So when there is progression, we just move to the rigid braces. I already explained you the bracing virtuous cycle. Just let's keep this in mind. The braces that do not correct in brace, they are not effective. How much correction should we expect? There is not a real rule. In the literature is published the rule of at least 30%. Some other colleagues says if it is less than 40, 50%, you don't have results. What I can tell you is that the correction depends a lot on the rigidity. And we also perform in brace X-rays, but sometimes in curves up to 40, 45 degrees, we have only 10 degrees correction. That means is less than 25%. What should we do in those cases? We recheck the brace, we re-verify if we can, with comparing the brace and the patient with the X-ray, and we check if we can do something more according to the X-ray in pushing in some areas, and we can feel that the spine can be corrected more. So this is what we do when the correction is not good enough, but we cannot just stop bracing because still we are obtaining something. And that is also correlated not only with the efficacy of the brace, but also with the rigidity of the curve. If the curve is too rigid, you do not achieve too much correction with the brace. but still it's important that you achieve correction. If you don't achieve any correction, you for sure are not stabilized. You can perhaps stabilize, you can perhaps still stabilize, but you have to remember that when you take out the brace, usually the patient collapses posturally, so you lose correction when you are without the brace, and that makes a real difference. The correct prescription of braces is between, let's say, 20 degrees, even if sometimes in very young patient, you can start with spinal cord even earlier, and 60 degrees. Less than 20 is for sure over treatment. Above 60 is doing something that can be important for the patient, because the patient don't want to be operated, but we have to know that we will not get out of the surgical area. So we are not really changing the life of the patient. We have to know it, the patient has to know it, then the patient can have the decision to stay there and to survive even in adulthood with this kind of scoliosis, but they must be aware. It's their decision, it's not our decision. Which brace is more effective? No answer. We don't have today an answer. The only answer is in terms of material. So the material make a difference, but we don't have an answer in terms of type of brace. In fact, we don't even have an answer about the biomechanics of brace. When we performed this study years ago about which is the vector, the best vector to achieve the correction, we found differences that were explained according to the type of brace the responder was using. So biomechanics is conditioned by the brace. In fact, it's not the scoliosis who tell the biomechanics of correction, is the brace that tells the biomechanics of correction. So at this moment in time, there are a few effective braces, and I will present them to you in a few minutes, that are used around the world. But what counts more is the expertise of the prescriber and the expertise of the builder. So a few years later, we found an agreement, not on the biomechanics, but on the management of patients with idiopathic scoliosis. We know nowadays that you must be an expert, and for expert, we define a physician prescribing at least 200 braces per year, or an orthotist building at least 300 braces per year, who have worked at least 2 years with a master. So you need to acquire knowledge to be able to manage properly braces. I can tell you that in my personal history, it took to me 10 years before I could claim to be an expert in bracing. It was a very, very, very slow understanding and growth. Nowadays in my institute, where all our physicians used to treat those that work full-time with us, having treatment 500, 600 minimum scoliosis patients, each of them. And it takes to them 2-3 years before they understand bracing and before they become creative. So be able to introduce new innovations, it takes another 3 to 5 years. Some arrive earlier, some arrive later. There is also the individual capacity, but remember, braces require expertise. Expertise comes from experience. And experience comes from following someone working hard in this field. So it's not enough to study. To study is mandatory. To study is highly important, but then you need to practice and practice a lot. And this is really a key element. Reeser, that was the inventor of the Reeser score, used to say, and was also the inventor of the Reeser casting. He was a huge expert. He used to say scoliosis should be identified by many, but should be treated by few. And that is true. In our country, we have a definition of rare diseases that is disease that hit less than one patient every 500, so 0.5% of the population. And braces are prescribed to around 0.5, 0.7% of the population. And rare diseases must be treated by institute specialized on rare diseases. And bracing is something like that. Historically, we will follow an historical path. Historically, we had the Milwaukee brace that really has made the history of scoliosis. But nowadays, the Milwaukee brace is not prescribed anymore, even in Milwaukee. I gave a course some 7-8 years ago in Milwaukee. And when I told them that in Italy, there were some physicians still prescribing the Milwaukee brace, they said, you're crazy, not even in Milwaukee, we don't prescribe it anymore. There are a few physicians around the world still using it, but the Milwaukee brace bases its action on the elongation, and the elongation create on one side a straightening of the scoliosis curves, on the other side also a straightening of the whole spine, reducing the kyphosis and lordosis. And in fact, the Milwaukee braces in that sense favors one of the pathological action, the distortion of the sagittal curves of scoliosis. So you can still find around the world some people prescribing the Milwaukee brace for infantile curves or for the cervicothoracic curves. But nowadays, the big experts do not do it anymore, because even with little kids, you can use thoracolumbosacral orthosis without creating distortions to the thorax. The only thing you have to do is to change very frequently the brace. And this is the fear of people who still use the Milwaukee brace in the infantile curve, to create a compression of the thorax. Good braces do not compress the thorax. Good braces drive the development of the thorax. So you have area of compressions, but also area of decompression. And is enough to change the brace frequently. For cervicothoracic, we also have some tools, but cervicothoracic curves are less than 0.1% of the whole scoliosis population, so are really very, very rare. The Lyon brace is still used quite a lot around Europe, was developed in the 50s in Lyon, and it is based on already on very rigid material, but the building in little pieces make this very rigid material bending at the boundaries when it finishes. So this very rigid material is not used at the best of its possibilities, as it is done with other very rigid braces. So it has results that have shown to be less good than the last generation of very rigid braces. Let's call it a first generation very rigid brace. But that is also explained by the 3-point action of the Lyon brace compared to the modern last generation braces that we will see later on. Anyway, I grew up with the Lyon brace in treating scoliosis. I used it for the first 10, 15 years of my practice. I used to say is the Ferrari of scoliosis braces, treatment braces. And now we have found something better, but it's still a very, very good brace. The Boston brace was developed in the 70s in the US and spread all over the world. It's based on a pre-arranged molding that is adapted to individual patients. Nowadays, the Boston brace is also built by some using CAD/CAM technologies. The main characteristic of the Boston brace compared to other braces is that has a posterior closure, and that is something that many of us don't like, because where you need to have more stable the brace, you have more movement. So this is a brace that still used quite a lot, particularly in the US, but also in Europe. The PAS brace was developed also in the late 70s, the second part of the 70s, is only for lumbar and thoracolumbar curve. It was developed in Italy, and is an asymmetrical brace. And now I can tell you that we use it in Isico. Is very effective, but only for single curves, lumbar and thoracolumbar single curves. What's happening? What happened here? Okay. The Chenot brace is probably the brace you are also using in Ukraine. That is highly probable, because the Chenot went all over Europe to identify to train orthotists all over Europe. Is a very effective brace. Nowadays is also started to be used also in the US, and the results shown by the Chenot brace are comparable to the results we have shown with our braces, but with less aggressive. Manuel Rigo, that is probably the nowadays the colleague with the biggest expertise in Europe in applying, in scientifically applying the Chenot brace with its own version, stop its treatment to 50-degree curves, while we arrive at 60-degree curves with very rigid braces. So probably it's possible to expand the indication with other kinds of braces that are based on different concepts. Thanks again at the beginning of the 80s, the first one, they are overcorrective braces. So with a nighttime brace, you cannot stand up because you are totally bent to one side. And they are shown to be quite effective, but not as effective as daytime braces. So they are used, some published also results better with the nighttime braces than with the daytime braces, but there is the strong suspicion in the scoliosis community that that happened because the patient were not wearing the brace during the daytime. So there were not compliancimeter on those braces and those studies. So we don't know really how much the braces were worn really by the patient. This is the Rigo Chenot brace, is the variation that has been developed in Barcelona by Manuel Rigo in the 90s. And he also proposed a classification to allow the development of the different kind of braces. Manuel Rigo is an incredible person. He's a PRM physician but he's also an orthotist, and he built the brace himself, and he has shown really very good results. He's one of the founder of Sosort that I presented you at the start of this presentation. In 2004, we had the chance to develop our own brace, and I say we had the chance because it happened really by chance, and it was. And I will give you some information about our braces later on during this lecture. We developed the Sforzesco brace that is the first of the very rigid new generation braces that was followed 10 years later by the art brace, or as it is being called also by his developer, Jean-Claude de Mauroy, the new Lyon brace, because it is developed by in Lyon as well, by the biggest expert of the Lyon brace, that was Jean-Claude de Mauroy. The interesting thing that was that for both of us, Jean-Claude and myself, also Jean-Claude is one of the founders of Sosort, the need to develop a very rigid brace came from the fact that for different reasons, it's not possible anymore to provide casting to the worst patient. And for that reason, we were obliged to develop something new. So it didn't come from a biomechanical thought or something like that. Both of us were very satisfied with the classical Lyon brace and the results of the classical Lyon brace, but we were also using casting in the worst curves above 45 degrees, in fact, even above 40 degrees. And the fact that we were not able to propose cast anymore to the patients obliged us to move to these new braces. A few years, in fact, in 2018, we met all the biggest experts. You can see myself down there, Jean-Claude de Mauroy here, Manuel Rigo here, Tomasz Kotwicki here, Tim Resco and Jim Wynn, the experts of the Boston brace here, Luke Stickleder, a big expert on the Chenot brace. Down here, there is Jeb McAveney. So these people are. This is the developer of this. Not the developer. The biggest expert still working on the spinal cord brace. Andrew Mills. So we all met to develop a new classification of the braces that happened in San Francisco in 2018. And we developed this new classification that you can see here. So we can classify nowadays the braces and the classification has been approved. We are missing only the final approval of the Scoliosis Research Society, but has been approved by Sosort, ISPO, POSNA, and has been supported by the European Society of Physical and Rehabilitation Medicine as well. And it will be published before the end of the year. And you will find all the details in that paper. It's based on the overall action of the braces. And we have elongation, that is the action of the Milwaukee brace, movement, that is the action of the spinal cord elastic brace. 3 points, the biggest example is the Chenot, the Lyon brace, push up, that is the Sforzesco brace, bending, that are the nighttime braces, and the torsion, that is the Chenot brace. Then we have rigidity, very rigid and elastic, the anatomy, so the area covered by the brace, the primary corrective plane, that can be also a combination of these primary corrective planes, and then the valves, so the number of valves that are connected to build the brace, and the closure. And according to this classification, we have been able to classify all the different brace we've published result in the literature. And most of all, we have been able to group some braces. So for example, while the art brace and the Sforzesco brace are in different groups, the two bending braces include the nighttime braces, Charleston and Providence. The torsion monocot include the Chenot, the Rigo Chenot, and the dynamic, the rotating brace, and so on. You can see this classification allow us to put together some of the braces that have been published, so to move the results of one brace and to apply the results of one brace also to another brace. So we can move forward from the previous classification that is just based on names to a classification that is based on what the brace is expected to do. And I really invite you to read the paper as soon as it will be published in a few months. So we have a few seconds while I drink a coffee for you to ask a few questions on the generalities, and then we will move to the brace we use in our institute.
Thank you, Professor, for concentrated information about the newest achievements in rehabilitation and treatment of scoliosis. And I invite with Professor our colleagues to ask questions. And while colleagues try to type their questions into our chat, I have a question. You have told that you have told in the second part of your lecture that training of an expert to prescribe and to control the effectiveness of different types of corrective tools in scoliosis need from 2-3 to 5 years. Do you have a training course for physicians or maybe physical therapists, existing program that can help to our colleagues to participate in it and to have this system in our country and to provide it in our patients?
We have a master, an online master that you can follow directly from your home that is developed exactly for physicians, in which we don't train only what we do, but we also train what the others do around the world. We have, I will have a slide to show you, or if you, since you asked the question, I will just show it immediately. Okay, I just share the screen again. Okay, this is just to introduce you to our online master course. Mm-hmm. These are the 25 lecturers from 11 countries and 4 continents. 21 have been presidents or award winners of SOSORT, SRS, and ISLS. So the two main most important scoliosis and the most important lumbar spine society. So incredible people that join us in producing this master course. This is the faculty for 2021. In these years, it exists since 5 years. We trained 221 participants from 51 countries and all the continents. As you can see here, we trained 81 physicians, 53 chiropractors. In some countries, they are providing treatment for scoliosis, 45 physical therapists, 18 orthotists, and 4 others. It constitutes of 16 live lessons because we have 16 theoretical modules. And during these modules, there are 42 self-administered lectures, so pre-recorded. So people see the lectures before the live lesson, and then they start an online discussion group that is moderated by us. They arrive at the live lesson after having understood well what has been learned in the self-administered, and then they have papers to read, 3 to 6 per each module. It lasts a few months, but is really very, very comprehensive. And nowadays is already translated in Chinese. We have the translation also in Spanish that will start in 2022. So it's really becoming a tool for the whole world because it's online. So you can do it easily at home. And that is the really a tool for physician. Has been developed for physician. For the physiotherapist, we have courses on CS. CS is the approach that we use. I will tell you later. That is done by Michele Romano. I will have a short movie to introduce you, and we will present a little bit about the CS exercise, not introducing the course, introducing what are the CS exercises in the view of a physiotherapist. And that is now in Russia, we are giving it online because we have a well-trained physio there who is able to make the movements while Michele is explaining. But we are moving now to a model with partly online and partly live, because there is required the live part. While for physician is not so necessary, it's not really necessary. For the orthotist, we have never been able to develop a comprehensive course because it's really hands-on. It requires too much hands-on. We will propose the first online course before the end of the year for orthotists. That include also the possibility to come to Italy for a few days for practice in our orthotist centers. But we have also developed recently a new brace that can be is modular, is really a new concept, and we have found that it's as effective as the classical brace. So we are now trying to reach an agreement with a worldwide distributor that will allow to create the whole package also for giving braces abroad, high quality braces abroad through the local orthotist. So you don't require to train that much, but you can have the instrument ready to go, and you have only to do some adaptations. So it's really a process that we are doing in this year to allow patients all over the world to achieve the best possible results. This brace possibly could be available, is already available through our institute. We apply the brace in India, we apply the brace in Singapore, we apply the brace in Colombia. So we are already sending the brace in various countries, but we are trying to find an agreement with a big distributor to have a wider possibility to help people around the world.
Thank you, Professor. It clearly looks like an invitation for further collaboration and for trainings. And I think it would be good when you will share with these links. We will share with our colleagues, and we will try to organize these trainings to have more effectiveness for the collaboration in this area. Because okay, you are the best in this direction, so we would be happy to be in this team too.
You are too kind. I'm not the best. There are other colleagues that are better than me, but I will do my best. Let's say like that.
Thank you very much. So, colleagues, do you have some questions for this part of lecture, or we can move
Otherwise,
on?
we can move forward because we have still.
Okay. Let's move on. Let's move forward.
Okay, so let me go back. I will move quite forward about our own, quite rapidly about our own braces. but I will just give you some understanding on how we work. So we apply at this moment in time these braces for scoliosis. I must say that around the world there are usually groups that apply one single brace. We don't think is the best way, is the most appropriate. We think that the more tools we have, the more we will be able to treat different patients and in different ways. So nowadays we are using the PASB brace, that is the one I've shown you, developed the PASB progressive action short brace, and we use it for the lumbar and thoracolumbar single curves. It's made on rigid material. Then we use the Sibylla brace for the double curve and the thoracic curves. That is the rigid plastic polyethylene version of the Sforzesco brace. That is the brace that we have developed in this year. While for the high degree curves, we use the Sforzesco brace. That is the very rigid brace we use for all topographic curves. Then we have the mixed cases in which you don't have only scoliosis, but you can have, for example, associated an hyperkyphosis, so a lumbar scoliosis with an hyperkyphosis, or you can have a spondylolisthesis. In these cases, we use the Lapadula brace that can be strengthened with aluminum bars when is needed, and is still polyethylene, so it's rigid but can be made very rigid with the use of aluminum bars, or we use the Sforzesco brace again when we need high rigidity braces. So this is the PASB brace, is asymmetrical, and in a nutshell, the brace is based on the one side that reach the apical curve, and the other side that reach the cranial limiting vertebra. So here the apical vertebra, here the cranial limiting vertebra, and the brace can move toward correction, cannot move toward progression. And then there is the rotating system. So we, as you can see, pushing more on the prominence on the other side. Much more this, but anyway, we don't have time here to go more in details. The Sibylla brace is a polyethylene version of the Sforzesco. This is the Sforzesco brace, and they are the most symmetrical braces that are available in the literature. And I will spend a few words after that, and we'll speak about the Sforzesco and the Sibylla. While the Lapadula brace, as compared to the previous ones, instead of having this kind of closure on the anterior part, they have a clavicular pushes here, so they are closed differently anteriorly to correct also an hyperkyphosis. The prescription, this slide would require really 1 hour just to be explained. Why we use one kind of brace and one kind of material with a minimum or maximum of hours according to the aims of treatment. So I will not go in details here. I'm sorry, but I should take out 1 second. I thought I did it. Okay. Now we will not have any more the slides moving forward by themselves. So let's go back. Okay. This slide would require really long explanations, and if you will participate to the course, there will be time enough to go into details about how much to prescribe, which kind of material according to the different aim of treatment. But now I want you to understand that the Sibylla used to say, in fact, it was a phrase of I think it comes from Cobb himself. The treatment of scoliosis is a menu a la carte. You have to choose the appropriate tool according to the need of the individual patient. So it's not a standard treatment. And the choices are based on the need. And in this table, you see the needs of the patient and the choices that you make in a shared decision-making environment. So if you want to deepen the knowledge about the Sforzesco and Sibylla braces, that are the braces we use in our institute, you can find this paper online, and you can have a lot of information there. Our paper is based, our brace is based, is the most symmetric brace you can find in the literature, even if it is not totally symmetric. As you can see here, this is the trunk of the patient. This is his external deformity. And for example, if you look at how we build the brace in terms of correction at the waist, you can clearly see that is not totally symmetrical. But in the meantime, we make it as much symmetrical as possible to make it as much patient-oriented as possible, because we want the patient to not to show to be able to mask completely her under the dresses. You know, we are in Italy, and in Italy, girls love to dress well. And I took this photograph during one brace check session. Usually we do the brace check together with the orthotist at his orthotist shop. We go there once or twice a week to check all the braces they have produced in that week. And there was this girl, and you can see the choices she has made. Look at the string of the shoes here. Look at how she's dressed with this very close jeans. And I saw her like this after checking the brace, and I told her, "But are you wearing your brace?" And she said, "Yes." So I asked her if I could make a photograph. If you look carefully, in fact, you see a little bit the brace over here. You see a little bit the brace here and here. But in fact, she's able to dress according to the fashion, even with the brace on. And for me, this is a quality of a brace. Is allows the patient not to show it too much, to dress how she wants, so that this, in my way of thinking, increases a lot the compliance. And our braces are made to allow the patient to be totally active, giving complete freedom of movement. And we encourage patients to do as much sport as possible with or without the brace, because we also want in this way to make him psychologically free, to increase the compliance. And also we think there is a role of the central nervous system in bracing, because you put an external device that is kept for many hours per day, and just think of the exteroception and the changed proprioception of that trunk into that brace. So it's true that there is a biomechanical action, but is also highly probable, not shown anymore. Not that we don't have proofs at this moment in time of this role, reconfigurating role on the central nervous system of this shell that is surrounding the trunk of the patient for months, for years. But I'm sure there is an action there as well. And the more the patient moves, the more this action is increased at the level of central nervous system. So we truly believe that the more the patient moves, the better it is. And these are patients who sent us photographs doing their preferred sport activities with their braces on. These patients learn to do climbing with the brace because you are not used to climbing before, and she learned with the brace on. And these are patients doing their everyday activities with the brace on. And I used to say, when I discuss with my colleagues that prefer the very highly asymmetrical braces like the Chenot brace, that the day I will have the final proof that the asymmetrical, highly asymmetrical braces are more effective than the more symmetrical braces we use, I will change to them. But until that moment, I will not, because of the better life I give to my patients using a more symmetrical and less visible patient brace. Also, I know that we are the group that has published the highest compliance until now in the literature using compliance symmetry. In fact, since almost 10 years, a little bit more, we are using the thermobrace that is a compliance symmeter in all our braced patients, and we check how much they wear the brace. And our median compliance is around 94% and published. So we can achieve an incredibly high compliance when the other groups publish no more than 75% compliance to what they ask to the patients. And we are really convinced that this has to do with the brace. The other thing that we developed with our brace is the three-dimensional correction that is based on as much kyphotization as possible into the brace. And in fact, when you see our patients wearing the brace, you usually see their the anteposition of their shoulders. This is something that parents and mothers usually don't like. They say, oh, my kid is bent forward by the brace. I see these shoulders coming frontally with the brace on. And we have to explain to the mothers that scoliosis is driving their kids to hypokyphosis, to a straight back, to a flat back, sometimes even to a hollow back. And what we try to do is to reconstruct the kyphosis. So you don't have to push back the shoulders normally in almost 95% of the patients. Contrarily, you have to antepose the shoulder to facilitate the kyphotization and not to have a loss of the sagittal plane into the brace. This is something that is not so well understood internationally and globally. And this is probably one of the biggest, let's say, element we are trying to, we introduced in our brace, and we are fighting really to keep as much as possible kyphosis and to let people understand that this is highly crucial. What we know, and everybody knows at international level, is that when you have a flat back, a hollow back, you have lost your battle against scoliosis, because all the braces, whatever we do, push some partially from behind. because from behind is the way we can push better on the spine. We can also push a little bit frontally from in an anterior-posterior direction, but this anterior-posterior push acts on the weakest part of the ribs, so it's not so much effective as a posterior-anterior push. And this posterior-anterior push can be provided only if we keep the kyphosis. As soon as we have lost the kyphosis, we can only provide a frontal push that will not be as effective as a posterior frontal push. So if we want to keep fighting against scoliosis, we have to keep as much as possible the kyphosis. The other thing that we introduce with our brace is the concept of working not on the curve, but working on the slope. What is the slope? Each curve has usually two slopes. One is below the apical curve, and the other one is above the apical curve. And with the Sforzesco brace, that works on the Sforzesco brace, it doesn't work in the Lyon brace, it doesn't work on the Chenot brace, it works only on the Sforzesco brace. You don't act on the apex of the curve, you act on the slope, and then you search the drivers. What are the drivers? I cannot go too much in deep into all this biomechanical thinking because we don't have enough time to go in deep here. But the other concept we introduced with the Sforzesco brace is the driver. The driver is the deviator of the forces, and you give in a bottom-up direction on the spine and deviate the forces to make the push up that we provide with the Sforzesco and Sibilla braces to the spine of the patient. In a way, we counter the collapse of the scoliosis through a pushing up action. And we used to say that the Sforzesco brace is an upside down Milwaukee brace, while the Milwaukee brace straightens the spine with an elongation action. With the Sforzesco and Sibilla braces, we derotate, detort the spine, causing a pushing up action that is achieved through the action on the slopes and through the drivers that deviate the biomechanical forces we apply on the spine. And so the final action is not just straightening, is detorting, pushing up, keeping the three-dimensional correction of the spine. The other element that is crucial, together with the slopes and the drivers in our brace, is to keep an overall balance. So we think of the correction of the spine in each one of the three planes. So we think on the deflecting pushes that are on the slopes. We think on the derotating pushes that are on the prominences. We think of keeping the kyphosis through the shell, keeping the sagittal plane through the build of the shell. But also we have to keep an overall balance, because if we don't keep the balance, what we lose usually is the sagittal plane. I cannot go more in details, but you can understand from what I've told you until now, there is a whole concept, a whole biomechanical understanding behind building the brace that is really not just simple push here, push there, and it's really something that require a greater deepening. And if you want, we will have the Sforzesco brace course before the end of the year, so I will let you have the information about this for your society. We don't have enough time here to go too much in details about the results. This is a paper that is under review now, but I just will show you this result. We've compared the study, the BRACE study that you have seen before. The BRACE study is the study published in the New England Journal of Medicine, in which there were 27% of failures, so of patients reaching the end above 50 degree in patients with research 0 to 2 curves, research 0 to 2 patients with curves between 20 and 40 degrees. In the same population, we have 1.9% rate of failure. And this is not the result we are the only one achieve all over the world. The same results have been published by Aulisa in Rome using the using the PASB and the Lyon brace, and has been published by Jean-Claude Mourois in Lyon using the Lyon brace, and has been reported by Rigo in using the Rigo-Chenot system. So even the expert in scoliosis using their own braces are not able to avoid surgery to 100% of the patients. Rigo has found 5% of failure. We and Jean-Claude Mourois and Aulisa have found a 2-3% of failure. Even in these cases, you cannot achieve 100% results, even the best expert. And scoliosis has been called by Cobb a constant lesson of humility, because we always lose the battle sometimes. It's not possible to achieve 100% results. This is just to show you the last innovation that we have introduced and we presented this year at the SRS and the SOSORT. This is the free pelvis. So semi-rigid material introduced in the high rigidity braces, and we have shown similar results as the high rigidity braces. This free pelvis achieves better comfort for the patient and also allow better adaptation of the pelvis and better results on the sagittal plane. We achieved the same results in terms of Cobb degree and the same results in terms of aesthetics and reduction of the prominence. And then similar results on the sagittal plane. And this is the modular brace, as what I was telling you, that is based on the free pelvis and an innovative posterior closure. And again, also with this modular brace, we achieved the same results on the Cobb degree and the same results on the prominence and on the aesthetics. So a very short question and answer on braces before moving to exercises and giving the last minutes of the talk to the exercises.
Thank you, Professor, for this part of the lecture. Our colleagues can very quickly type down their questions, even in Ukrainian. I will translate. But the first question that is commonly asked in such cases is, who will pay for this in treatment and rehabilitation? What is the system of financing of this type of treatment in Italy? And from your opinion, what is the best way? Is to self-paying or maybe some state programs of monetization of this type of treatment?
All over the world, the treatment is usually paid by insurances. These insurances can be health national insurances, like in Italy, or can be normal insurances, mainly in the US. In Europe prevails the health national systems. Usually braces all over Europe are paid by the health national systems. In Italy, only the spinal cord is not provided by the health national system, so patients who want the spinal cord have to pay by themselves. Our institute is fully private, because so our patients pay for the physiotherapy and pay for the medical consultations. That is also one of the reasons why we have so few medical consultations, 2 per year, and so few meeting with the physiotherapist, from a minimum of 4 per year to a maximum of 10, 11 per year, no more than that, to reduce as much as possible the cost for the patient. But this requires huge expertise and very good management. And this was not possible in the current health national system situation in Italy. So that is, so we have medical and physiotherapy session in our institute paid out of pocket, and braced paid by the health national system. Other colleagues work totally in the health national system, so everything is paid by the health national system. But for example, they are not able to provide physiotherapy properly, and so that creates a lot of problems.
Thank you for answer, Professor. We have one more question. Does this new modular bracing technology can simplify the production and adjustment of brace?
Yes, it does. This is the reason why I would say almost 15 years that we are trying to find a solution that could help the production of braces and move forward, instead of the current personalization based on CAD/CAM or casting. And this modular brace, in our opinion, is the way to overcome the need of the absolute need of the CAD/CAM. That was what we had until today. What we are trying to achieve is a better spread of the knowledge all over the world. We are not saying that CAD/CAM will die. Probably in our institute, we will continue to use a combination of CAD/CAM and modular, but modular will drop terribly also the costs, and will increase the availability also in low middle income countries where there are not money enough to pay for the braces. So this is why we have developed the modular, to spread. And also knowledge usually is limited to very few orthotists, but the people with scoliosis has much more than the few orthotists that can develop properly the braces. So that is why we need something else to increase the availability of treatment widely into the world. So probably I think that the experts will continue to use CAD/CAM and casting, but others will also move to this modular brace.
Thank you, Professor. Maybe it will be the last question for this session. You have answered on the part of this question, but we have the question. After taking braces, what are the chances of regress, and what are the chances of stabilization of results of this treatment?
Okay, thank you very much for this question, because I didn't say that. So first, it's not true that scoliosis doesn't improve. Scoliosis improves, and in our statistics, improves on average between 7 and 9 degrees, but this average includes some patients who progress and some patients who improve 20 degrees. So is not, the average doesn't tell that much. In terms of percentage, at the end of treatment, we have around 50% of patients, 50-60% of patients who improves at least 5 degrees. And we have 2% of patients, as you have seen, who progress up to 50 degrees. And we have probably 5, 6, 7% who progress more than 5 degrees. So the results are quite spread at the end of treatment. Obviously, these results are related to curves between 20 and 40 degrees, Richter 0, 2. So if you have worse curves, results are worse. If you have better curves, results are better. So you have to adapt these results according to the age of the patients and according to the quantity of COP degrees. Then we have proofs that patients treated at the end of treatment and after end of growth can still progress. But this progression is, we don't know if this progression is worse or similar to the progression of not treated patients. So at this moment in time, is safe to think that if you finish below 30 degrees, that is the threshold that is not causing progression, also according to natural history, probably this patient will not progress. While if you finish above 30 degrees, there is progression, increases, as I have shown you, rapidly up to 50 degrees when the risk of progression. So at the end of treatment, probably is safe to think correspond to the risk of progression as per the natural history. Because the progression in adulthood, as far as we know, is due only to degeneration due to biomechanics alterations. So if that is true, progression should be the same. But if you end treatment with a good aesthetics, with no decompensation, with a patient well-centered, and this is the normal with bracing, probably is also possible that we are reducing the risk of progression compared to the natural history. But this is just an hypothesis, as a probable hypothesis, but only an hypothesis. So we cannot rely on that at this moment in time. We have to rely on natural history and see what happens in the long term. And the studies at this moment don't really tell us a lot.
Thank you, Professor. I think that was the last question. Too many thanks for you for this lecture. And maybe I will ask the last, maybe bridge question between previous and the next part of the lecture. What types of sports activities do you recommend to your patients to participate? Cycling, kayaking, or something else? Maybe you will answer this question in your further report. So it is a question that frequently asked in our patients.
Great question. Thank you for raising it. We don't have any data about sport that is damaging scoliosis or sport that is improving scoliosis. We have data about exercises, specific exercises that can reduce the rate of progression. So I used to say to my patients, sport builds your capacities on which the exercises build up, because this is our common experience. Very sporty patients are able to do much more complicated exercises and can achieve much more with the exercises, but that is still experience-based, not evidence-based. So that is, but we have data that agonistic rhythmic gymnasts make progress scoliosis. We have data that agonistic dancing make progress scoliosis. We have data that asymmetries are reduced in tennis, that asymmetries are increased in swimming. Not scoliosis, asymmetries, body asymmetries, trunk asymmetries. We published those results some years ago. So there is a great confusion. The only safe thing is that doing sport is good. And the other thing that we know, that nobody does the sport that she doesn't like. So what we say, do whatever sport, twice a week, you will not create damages, because the data we have on damages are on very agonistic sport. So a little bit of agonism is good, twice, 3 times a week. And we also published recently papers in which we have shown that doing sport 2-3 times a week improves, reduces the progression. These papers are under review now. We presented at big meetings of sort. And also when you are braced, the more sport you do, the better results you have. So let's do sport, whatever.
Thank you. No questions now. Maybe we will have a short break, or we will go on.
We go on because we have half an hour, less than half an hour.
Okay.
So I will move directly to the little talk of Michele Romano, and then after that I will add some things. So we will speak of exercises listening to him. Okay. Okay. Because he will speak around 10 minutes. So then I will complement what he has said to give you a little bit more understanding, and then we can have the last question and answer session. Okay. Sounds good. Let's share again. I move here. Can you see it?
Perfectly. Not sound.
You don't hear the sound?
No, no sound, but we have only picture.
Wait. Okay. Let me see if the sound in this way works. Can you hear? Do you hear? You are muted.
No sound yet. Maybe let's try again.
Yeah, but I don't think now probably it's not working. No, you don't hear it, no?
No.
Okay, so I'm sorry for that. Let me see if there.
Do you have sound on your computer?
Yeah, on my computer I have a sound.
We have no sound here.
Okay, I at least.
Maybe you will
show you one exercise just to give you the flavor of what it is.
Okay. Maybe you will comment some parts of the video.
Okay. Here you see the patient who performed the self-correction, then does an exercise, keeping the self-correction. You see the self-correction, and then at the end you will see she loses the lesser, and now she relaxes. You see the prominence. Okay, anyway, let's explain a little bit about exercises. First, are there results published in the literature? There is this Cochrane review that was published some years ago. We are now writing the new edition. And at that time, there were only 2 studies that were included in the Cochrane review that showed the effectiveness of exercises. Since then, many studies have been published. Randomized control trials have been published showing the efficacy of exercises. What are the aim of exercises? You can have exercises per se, and then the aim is to avoid bracing. And in fact, you will see the role of exercises standalone is at the beginning of the treatment. And then you have exercises as a support for patients wearing the brace. And those are a totally different kind of exercises. So when you are doing the exercises standalone, your aim is to avoid bracing. And to avoid bracing, we aim to train the functions of the patient that are able to counteract the pathological action of scoliosis. And this can act today to avoid progression and avoid bracing, but also probably in the future in adulthood. And to let you understand, let me go to one slide, because I want, this is highly important for us as physicians to understand what we are really doing with exercises. Exercises will never, ever be able to mimic in any way what braces can do biomechanically. Because even if, just imagine, you have a very compliant patient. This very compliant patient perform great exercises, is able to self-correct the spine incredibly, and is highly compliant. He do exercises 1 hour, 1.5 hours per day. But you have to consider that during the exercises, they perform the movement, then they go back, they perform the movement, they go back. So even in that hour, the correction can be achieved 50% of that hour. That means half an hour. So even the best compliant, the best patient can do no more, can be corrected with exercises no more than half an hour per day. Not comparable to the brace that is worn 18, 20 hours. Even if you wear the brace only 8 hours overnight, it's still 8 hours per day compared to half an hour per day. So what are there the exercises for? In fact, what is rehabilitation there for? Rehabilitation exercises are one of the most important tools for rehabilitation, but rehabilitation is there to change behaviors, to change neuromotorial behaviors, neuromotorial control. So exercises are meant to teach the patient a different way of motor behavior that will change the way she supports the spine and will reduce, so it will improve functions that will allow to the patient to counteract the direction that is taken by scoliosis. Since we don't know what is the cause of scoliosis, we cannot really teach exercises against the cause of scoliosis. Nevertheless, we know that some patients with scoliosis have balance issues. We know that some patients with scoliosis have weak muscles. which kind of muscles are weak, the one of convexities or one of concavity. Is a nonsense reasoning, because studies in the literature have shown in some cases stronger muscles on concavity, in other cases stronger muscles on convexity. So we don't know. And also the concept of concavity and convexity is a concept on the frontal plane, but we have seen how scoliosis is a three-dimensional problem with a concavity that is three-dimensional. So do you know which muscles are really acting on that specific scoliosis, helping that specific patients in achieving the best possible correction, and which of those muscles are weaker and which are strong? That is really a reasoning that is much beyond our understanding nowadays of scoliosis. But we have this kind of understanding that I can show you with this slide. This graph comes from a paper, a very old paper, 1978, that was published by Madame Duval-Beaupère. Madame Duval-Beaupère was one of the biggest expert of scoliosis in the 80s. And she was thinking of terminology. And thinking of terminology, she was thinking of interested in defining rigidity of the curve. And to do this, she compared 3 radiographs. Those were the years in which patients were submitted to plenty of radiographs. It was very common to perform not only the standing X-ray, but also the lying X-ray. So let's imagine a patient with a 40-degree scoliosis standing, and then you put the patient in lying, and the curve always decreases when you are in lying. And let's imagine that the curve goes to 30 degrees. Then let's imagine we put this patient in a cast. We push as much as possible to correct the scoliosis. And we end up with a curve of 20 degrees in cast. Now, this was very common with casting, is very common with bracing. It was also very common with the Harrington correction of the curve. The Harrington was the first instrumented correction that was presented by Harrington in the just before the Second World War and just after the Second World War. And this correction was based on 2 hooks placed at the 2 extremes of the curve, and then a bar that was gradually lengthened to stretch as much as possible, to lengthen as much as possible the curve. And the Harrington rod at the start was applied only on the concavity. Then it was applied one distracting on the concavity and one also on the convexity, compressing. So the variation arrived. But what was common with the Harrington rods was that it was never ever possible to achieve the total correction of the curve. You used to stretch the curve, and then you reached a maximum, and then the correction was not possible. The best correction that are achieved nowadays, and you can see even straightening of the spine, those are achieved because some part of the bone is taken out, some other parts are inserted. So you have really a complex correction, including destruction of the bones. But if you don't destruct the bones, if you don't change the bones, you will never ever achieve a complete correction of scoliosis, even with surgery. So there is a structural, not modifiable part of the deformity in all the scoliosis we see. And this structural part cannot be corrected, and is due to the bone deformity, together with a retraction of ligaments that cannot be overcome simply pushing on the spine. So that is the core of the deformity. Then above that, you have another part that you can correct pushing externally. And this structural part include the rigid and the elastic components of the structural part. So when you push externally, you can stretch some ligaments that are retracted to a certain level, and not completely, because these ligaments at one point reach the end of motion. And this stretchable ligaments part is the correctable part of the structural scoliosis. So you have a not correctable. Then above that, in this case, is the difference between 20 degrees and 30 degrees. You have 10 degrees of correctable structural deformity. Above that, you have the difference due to the gravity force when you move from lying to standing. And that difference can be considered as the postural collapse under the gravity force. But this postural collapse is limited by the neuromotorial capacity of keeping the postures. And this is where we act with the exercises. If we are able to reduce a little bit this postural collapse, we can reduce the structural constant load on the bones that causes that vicious cycle that we were speaking about before when we were speaking about the Stokes vicious cycle. This is on the static side. Then there is a dynamic side that means increasing the way the patient moves better without charging the scoliosis. And this is something that we conceptually knows exists, but we don't have any studies at the moment on this part that really allows us to understand what we are doing on the kinetic part of the possible correction. And that is really something that I see for the future. But at the moment, we still think statically of scoliosis. And we are still struggling to learn to think three-dimensionally of scoliosis. And we are not at all thinking dynamically of scoliosis. The only instrument we have nowadays that thinks dynamically is the spinal. The surgeons fix the spine, even if they are also moving to some surgeries like the tethering or the stapling, in which they still allow the patients to move. But we are really very, very far to start understanding. And really, I do hope in the future to see more studies. There are now some studies with gait analysis, but still they look more at the limbs than what they look at the trunk. So we are doing something on that area, but really, I cannot say we are really understanding completely. So this is the reason why in the virtuous cycle exercises, I introduced, together with the improved posture that I have told and I shown you with that graph, also the improved movement strategy. But this we hope we are inducing with our exercises, but still there is a lot to go. But now I go back a little bit to give you some more information about which exercises. This is an old paper, 2005, at the beginning of SOSORT, in which we try to reach a consensus on what we were doing with the exercises around the world. And the consensus was achieved around the concept of autocorrection, so three-dimensional autocorrection, and exercises that do not provide a three-dimensional autocorrection are considered nowadays not specific for scoliosis. The way we achieve autocorrection is totally different according to the different schools of exercises. And I will give you some example of the different schools that exist about exercises. And then stabilization. So strengthening the capacity of the spine to keep the self-correction in time and to change the posture toward self-correction in time. And then theoretical information for the patient and information about the activities of daily living. These were the items on which there was the highest agreement among the experts. The schools that exist, there is the side shift school. The side shift was invented in the 70s by Min Mehta in England, and this school is applied only nowadays in England and in Japan, and is based on a self-correction that is on one single plane, is the frontal plane, even if and is based on a hyper correction on the frontal plane repeated in time to make patients learn how to self-correct and keep a better posture. Then there is the Schrott school. The Schrott school is based on achieving the best possible correction. Keep in mind, best possible correction, even through external aids, and then the best possible correction is repeated and repeated and repeated and repeated constantly. And according to the Schrott school, the best correction is you learn one, maximum two exercises, and these 1-2 exercises are your exercises for the rest of your life. So there is really, and exercises are required to be performed 1 hour per day, every day. So it's really repetition, 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 repetition. Then there is another method that is the Lyon method. The old Lyon method was based on a self-correction that was auto-elongation. That is not performed anymore around the world, and it has evolved in the SIA school. That is the one we use and we promote in Italy. And someone has to close the microphone. The SIA school, that means Scientific Exercises Approach to Scoliosis, SIAS, is based on the active self-correction. The active self-correction is performed by the patients. You see here the patient on the frontal and the sagittal plane. This is the standard, her position. Here is her X-ray. And here you see the active self-correction without any external aid on the frontal plane and on the sagittal plane. The active self-correction is three-dimensional, so not only frontal, but also restoring the sagittal plane configuration of the patient as much as possible. And the active self-correction is in the CS school is the basis of that is taught to each single patient according to each individual curve. And what remains stable is the active self-correction. Then the exercises are disturbing the active self-correction, are challenging the active self-correction, so that the patient is required to do even very, very difficult exercises when he is very, very well trained. So the exercises change continuously. There are thousands of exercises in the CS school, because we do not aim for the best possible correction. We aim to the best achievable individually without external aids correction, that is then challenged with the exercises, so that the patient can learn how to keep the exercises even when he's doing active movements. So this is the big difference between the two most used schools around the world. The Schrott is born at the end of the 19th century, so is more than 150 years old school, and is based in neurophysiological terms. You are colleagues, you are physicians, so you are used to think of exercises in neurophysiological terms. When we want to learn something, there are two ways of changing motor behaviors. One is through repetition, and this is the one is applied, for example, by athletes doing athletics. So in high jump or in running, they repeat. Also in swimming, they repeat always the same gesture, and they learn to be perfect by repetition. And this is what Schrott does. Being perfect, the perfect exercise learned through repetition, obsessive repetition of the same gesture. And that teach the brain how to do that. But there is also another way. That is the one that is used in basketball, in volleyball, in soccer. You learn to do one gesture, and then that gesture is challenged to become a gesture that you can apply in your sport activities, even in front of different challenges. And this is the way that we use with the CS, in which the gesture should be as best as possible, but feasible in everyday life, and then is challenged. So is repeated that gesture. So you, every time you throw at the basket, or every time you kick the ball in soccer, or every time you and you always try to achieve that target, that is the basket, that is the goal, and in our case is the best posture, better posture, but challenged, so that in front of the different activities of daily life, so the sporting activities for the champion, the activities of daily life for our patient, you still are able to keep your corrected posture, your self-corrected posture. So you see the differences between the two preeminent schools nowadays in physiotherapy scoliosis specific exercises for bracing, and this also for scoliosis. This also explains why we require only 15 minutes per day, while the Schrott school requires 1 hour per day. Then there are variations of the Schrott school. The classical Schrott school required intensive rehabilitation, inpatient rehabilitation. Nowadays, there is the Barcelona Schrott school that requires only outpatient treatment, but still the big difference is in terms of intensity. Nowadays, the schools are closing up a little bit one to the other, and there are a lot of physiotherapists around the world that apply both the Schrott and the CS. The CS is much more feasible at home, much less boring for sure. In terms of current evidence, if we classify the evidence in terms of type of studies performed, and until the time of follow-up, we have one randomized control trial till the end of growth on CS. We have 2 randomized control trials, but during growth on SHROT, and then on the intensive inpatient rehabilitation, SHROT rehabilitation, we have a controlled prospective study, but not at the end of growth. On the Lyon, so you can see here all the different schools and the results published until now. So this also about the indications. Exercises can go between 10 and 25, 28 exercise, but with exercises, we do not expect improvement. We expect stabilization. So when we need improvement, it's much better to move to external aids, even if exercises are used with rigid and very rigid braces, because rigid and very rigid braces impair the quality of movement, impair the strength of the trunk. So you need to apply exercises that prepare the patient to live without the brace at the end of treatment. So you still apply self-correction, but you also apply strengthening exercises not to lose the movement capacities of the patient. So, okay, in conclusion, before the last question and answer, I invite you to go to the SOSORT guidelines and read them carefully, and you will find all the indications for scoliosis. And then there are, if you are interested in scoliosis and you want to do also research there, join the SOSORT Society. Of course, and our master course, our CS courses. There are also SHROT courses that are performed by Manuel Rigo. There are also courses on the Chenot brace that are performed by Manuel Rigo in Barcelona, and he's going around the world to teach the Chenot braces. And you can join our courses promoted by EASICO, and that's it. Now you can ask me all the question you want.
Dear Professor, thank you for the amazing lecture that we have received a lot of insights today. So it is an incredible experience for us. The first experience to try to teach in English, and we hope the next our experiences will be so effective like the first one. Thank you very much. Maybe, dear colleagues, do you have questions? Because we have a few minutes before we will finish. I want to say thank you very much to you, Professor, to the WAMS and to the European Society of Physical Rehabilitation Medicine. This is a chance for Ukrainian physicians, PRM physicians, and our rehabilitation professionals to be close to the best knowledge and best experience in rehabilitation area. We are very, very grateful to you for your support. I want to be thankful to our Ukrainian Society of Physical Rehabilitation Medicine, to our leaders and professors who build new connections in Europe and whole world, to our team who supported this lecture today, Yulia, Vitrova, Prisezhnuk, Vadim, who are out of camera, but they are present and they support us. So this is an example of big team work that help to everybody to be more efficient in all our efforts. Thank you very much, and we are waiting for your questions. What is the first question is very quick and concrete. What is the cost of online ICT education? If you know these numbers, would you please to answer?
I don't know exactly, because the cost can be reduced through your society. So if you reach an agreement, because if there is a number of colleagues joining from one country, it's possible to reach an agreement. I think the cost is around 2,500 euros, but we have discounts according to the income of your country. So I don't know at which level. We use the World Bank account, the World Bank classification of countries. So according to the level, but for high income countries is 2,500 euros for the 16, in fact is 16 live plus 32 recorded lessons. So it's really a huge amount of information. But for some years we had discounts through the ESPRM, and because ESPRM is also supporting the master. I don't know what is the policy nowadays, but I'm sure that through the society you can, if there is a group of you that want to join in, it's possible to have discounts. Quite interesting, I think.
Thank you for answer, and thank you for the link where everybody can know information, and we will try to establish relations between our organizations to help everybody who want to participate in further education in this area. Thank you very much, dear professor. If we don't have any additional questions, I ask to everybody to switch on their cameras and to make a photo to keep this this lecture not only in our mind, but maybe everybody will share with this experience on their Facebook or maybe Instagram pages, and maybe we will be friends to everybody, and this information will spread more quickly, more effectively, and it will be the best ground to the further educations, and we will achieve more our more rehabilitation aims of our patients. Thank you, dear professor.
I hope there were not too many people in pajama that are now running to put something on. Usually we are quite free when we are listening to these lessons online.
Thank you very much, dear professor. Okay, who want to who switch on their cameras, please do this, and we will try the final countdown.
You can also ask in Ukrainian.
Шановні колеги, хто хоче зробити фото групове, включіть свої камери, будь ласка, і ми зробимо це фото. Ви зможете ним поділитися в ваших соціальних мережах, відмітивши Стефано, Українське товариство фізично-реабілітаційної медицини, Rehab Hub. І таким чином ми зможемо поширити цю інформацію в майбутньому. Це може стати гарним підґрунтям для того, щоб ми могли запрошувати інших наших експертів і разом вчитися на досягнення реабілітаційних цілей наших пацієнтів. Зараз я почну зворотній відлік, зробимо кілька пробних дублів, і ми надішлемо вам ці скріншоти з електронними адресами, з якими ви були зареєстровані. Виберіть найкращі фото, які ви вважаєте за потрібним, і не тримайте інформацію в собі, діліться. Чим більше поділитесь, тим більше будете мати результати. Окей, let's start the final countdown. 3, 2, 1, smile. The first shot is done. I will save it. let's do one more shot to be sure that everybody will have an opportunity to choose the best photo. Okay, smile. Okay, and the third time, and it will be the last, so don't be so serious. Let's say together, PRM, cheese. Perfectly, the best photo from these 3 shots. Everybody is in the best way. We are looking like a celebrity stars. Thank you, dear professor. That experience, that lecture was very, very valuable for everybody. And
thank you for being here and listening.
Yes, thank you very much, and a lot of our professors who were not able to be present. They say hello to you, and we will meet in our further meetings. We hope that COVID will end somewhere.
Sure.
Somewhere, sorry, and we will meet in live meetings, in congresses, in training, and so on. Thank you very much.
Bye-bye.
Bye-bye. Good luck. Thank you.
Thank you. Bye.
Good luck.